Our first speaker, I'm honored to say, is a friend of mine and a colleague, Dr. Katelyn Bruno. She is an assistant professor of cardiovascular medicine at the University of Florida. She has affiliated appointments in physiology and aging and pharmacology and therapeutics. She also has a research collaborator appointment at Mayo Clinic, and she serves as deputy director of the Center for Regenerative Medicine. Dr. Bruno received her PhD from Johns Hopkins Bloomberg School of Public Health and completed her postdoctoral training at Mayo Clinic. Her research spans translational science, cardiology, immunology, and sex differences in disease. Please join me in welcoming Dr. Bruno.
Thank you. Thank you for having me here today. So today, as kind of the first talk, what I'm going to talk about is the creation of our EDS clinic at Mayo, which Dr. Knight ran for a long time, and we are very sad to not have him there anymore. But what I'm really going to talk about is how we form the clinic in focusing on integration of clinical care, of research, and patient involvement, and what that's led to. Thank you. That's helpful. At Mayo Clinic. So as stated, so I'm now at University of Florida, and I'm a professor there, but I am still the co-director of research with Dr. Fairweather, who will be speaking later at Mayo Clinic. And so what's really important about this is with our integration, when we started this clinic, it started with patients. So I actually have hypermobile Ehlers-Danlos, and this clinic started, and they wanted to bring the clinical care in. They integrated us from the very beginning. So they came to me as a patient who was doing research with my providers and was a researcher, and we built this clinic around patients, around research, and around helping patients in clinical care. And so I'm going to talk about some of our experiences. Oh, maybe this doesn't work. We'll just use this. Okay. I have nothing to disclose. So we're going to talk about our Ehlers-Danlos clinic at Mayo, some of our findings in comorbidities that we see in patients comparing hypermobile Ehlers-Danlos and HSD, and examine some of our clinic outcomes and patient feedback. Everyone here and on this call is going to have this, know this information. What we're really talking about here is hypermobile Ehlers-Danlos and hypermobility spectrum disorder, being the most common form of Ehlers-Danlos, affecting 255 million people, having a sex difference, and being a collagen disorder that causes a number of comorbidities, but no known genetic mutation. And it's really a clinical diagnosis. So when we wanted to help clinical care, when we were building this clinic, everything was focused on helping patients. So we started our clinic in November 2019. And from that very beginning, we started, yeah, that does work. Okay. We built an intake questionnaire that had research integrated into it. So patients would get this email before their appointment that Jessica would send out when she was there. And they would take this questionnaire that was over 400 questions. It would take over an hour to complete. And it contained a number of different questionnaires that helped us know what was going on with patients before they got into clinic. Because patients with Ehlers-Danlos every body system is affected. So then you need to collect a lot of information, and there isn't enough time in the day to collect everything about an EDS patient. And so we built this form with research in mind, but really with collecting the data that the clinicians needed in advance, so that when they sat down with that patient, they could really focus on what that patient needed next. And they already had the information about who that patient was and what they were experiencing. The other thing that we started from the very first patient is a biobank. So collecting sera, plasma, PBMCs, as well as blood for RNA analysis down the line. And so we started this from that very beginning. So we had the clinical data, we had the self-reported data, and we had our biobank. So this is an overview. This is how we the very, very beginning of our clinic, how we started it. And so this was the first paper we published after starting the clinic about our workflow. So patients could come in to the clinic by self-referral, referral at Mayo, or external referrals. Before the visit, there was a triage, the medical intake questionnaire. They're actually consented for research. They receive an email to say, are they interested in research even before they come to that clinic, and get some family history. At the clinic, they have a very comprehensive appointment, genetic testing if indicated, blood work, and then they actually have their research blood draw if they decided to consent. And then they're done with the research side of the study. After, they have some standard and optional tests that they can have, and then they get referrals based on what we find in this intake questionnaire, based on what's found in that medical consultation. They could have referrals to any area within Mayo Clinic or externally. But they all, at that very first appointment, get referrals for physical therapy and occupational therapy just to help educate them and help those patients. And then at the time we were doing, I'm not sure if they're still doing the follow-up video visits. Sorry. Yeah. So there's the video visit to discuss any results from testing. So, say they had any autonomic reflux screening, and then now they need to get a referral into the POTS clinic or things along those lines. So there's some follow-up there, and then a plan for where they're going to go. So this is the clinic that, this is how we built this clinic to help patients. But when we talked about that intake questionnaire and this hundreds and hundreds of questions and this hours of time that would take a nurse to collect when they first meet the patient, what we did is every question that was on that questionnaire, we were able to build into an Epic note. And so when that patient put their name in, when that patient put their age in, when that patient put where they live, when they said how long that they've had symptoms, when they talked about if they had easy bruising, if they had an echo, if they had any kind of symptoms related to potentially POTS. These questions says, the question would be, do you have dizziness from when you go from lying to standing? And they would say yes or no. And so Dr. Knight or Jessica wouldn't have to read through those hundreds of questions. They told us what questions do they really need to know the answer to before they even see that patient. And so what we did is we built this so that they could read this couple of paragraphs, these couple of results from some standard questionnaires, and have that information before the patient even walked into the room, and then copy paste this straight into an Epic note to save time so that they could focus on the patient one-on-one rather than the documentation. And so this is what was really important to us, is really to support the clinic so that everything could move smoothly. And everything then was also being able to be used for research. And we also collected follow-up and quality improvement data through these questionnaires. So what is our clinic? What is our clinic right now? So I pulled these numbers last week. So we've had over almost 6,000 patients have scheduled an appointment with the Mayo Ehlers-Danlos Clinic since 2019. Almost 5,000 have attended those appointments and completed that intake appointment. 95% have finished that intake questionnaire. They're sent reminders, but patients are busy, and sometimes that doesn't happen, which then they still can come to that appointment, and it's just a little bit more work for the nurse to collect that information that's needed. But 94% collect that extensive information that we're able to then use for a retrospective chart review and for research. And then 43% consent to our research blood draw for our biobank. And that's not done. That's all in advance. So they read the things, they can call, they can consent at the appointment as well. But this is a limited amount of work for our clinicians to do, because we send it out in advance, but we can then do research down the line. So what do our patients at Mayo look like with diagnosis? So here, what we have is the different possible diagnoses that the clinicians in the Ehlers-Danlos Clinic at Mayo give. About 25% of patients coming into the clinic, so this is of this almost 5,000, get diagnosed with hypermobile Ehlers-Danlos. 50% get diagnosed with hypermobility spectrum disorder. About 5% get diagnosed with the localized hypermobility spectrum disorder. 6% with the historical HSD, 12% get diagnosed with possible other connective tissue disorders. And then we have this, and let me say this is based, the HSD, EDS, and the other possible, we are using the 2017 criteria for diagnosing at Mayo. This control, this 1% control, so this is about 500 patients, these controls. These are not healthy controls. These are patients who think they have EDS. They are coming to the Ehlers-Danlos clinic to try to get answers, but they do not meet the criteria for any of these other conditions. And so we kind of have an internal control within our clinic of patients who are not hypermobile. They may have pain, they have other comorbidities, but that gives us a very easy way to try to understand what makes these patients unique and how can we help those patients specifically. Just some more demographics of our kind of patients. Our patients at our clinic are almost 90% white, 90% female, and 85% not Hispanic. So this is when I show you some of this research. And today you're going to hear talks from Dr. Fairweather and Shulpa. I'm really giving a big introduction, the big picture of the patients they're going to the data and the stuff they're going to talk about later. So this gives you an idea of who these patients are that we're seeing. So research, I'm a PhD scientist. I'm a basic scientist. My main research is in inflammation and cardiovascular disease. But as I mentioned, as a patient, I was having to do my own research. I was doing research, retrospective chart reviews with my clinicians, with my physical therapist, with my neurologist. And so when the leadership came to us, when they first came up with the idea of this clinic, they wanted to integrate research, and because they knew we were doing research as patients, me and Dr. Fairweather, they asked us to get involved from the beginning. And so we were able to start research, as I mentioned, from the very beginning. So I'm just going to highlight a couple of our big picture findings here, and then I know that you'll see more of our research later. This is a paper we published in 2024 where we were looking at similarities and differences between EDS and HSD. And so these are self-reported. This is that intake questionnaire that they take before that first appointment. This has everything from, as I said, demographics to self-reported symptoms and comorbidities to standardized questions like the fibromyalgia questionnaire, chronic fatigue questionnaires, work impact questionnaires. So all of this is integrated that we're able to do research on. So this paper really focused on 115 symptoms and comorbidities that could be reported. We had about 2,000 patients in this study. 93% were female. The average age was 34 years old. And this paper specifically focused on HEDS and HSD diagnosis. And so what you'll see here is comparing those symptoms and comorbidities. Patients with EDS had, there was about 8% of those 115 that they had that were more prevalent than the HSD patients. And these really focused around, the big ones were dislocations, hernias, and prolapse. Our HSD patients, they had 37% of those 115 that were significantly more prevalent than the EDS. And these were related to joint and muscle symptoms, neurological symptoms, and gastrointestinal dysfunction. And then the conditions that were really overlapping that both of these patients really had no difference and were really high were allergy and atopy and headaches and migraine. So these are some of our big picture findings. But in this paper, you can see all those 115, that data from every single condition, every question that we asked, and the differences. So these are some of those conditions of that 37% that were increased in HSD patients. So what you see first is blue being our HSD patients, gray being our EDS patients. And these are grouped by kind of condition type. So you've got joint and muscle, allergy, neurological, gastrointestinal, sleep, and psychological conditions. And this, you can look at all the list of all of them, but what you're finding here is in this slide, these conditions were significantly more prevalent in our HSD patients compared to our EDS patients. And then the conditions, that 8% that were increased in, this is just a snapshot of that in our EDS patients here, with the gray having a more reporting of this, include like we said, the dislocations, prolapse, hernias, and things like that. So these are just, we want to start understanding who the patients are, what they're presenting with, so that we know how to help every patient on an individualized basis. So another study that we just published in 2015 took this a step further. So originally, when we first started the clinic, we grouped patients with localized hypermobile spectrum or hypermobility spectrum disorder or historical HSD in with the controls, because they did not meet criteria by the 2017 criteria for EDS, and they did not meet criteria for HSD or other connective tissue disorders. So they got lumped into a control category. But Dr. Knight and the team at Mayo Clinic were making notes in these patients' charts, say if they had localized, so they have a joint area that may not focus on be part of the Beighton score and things along those lines, or they would have tested positive by the 2017 criteria historically. So, or they had a historical diagnosis. And so we then pulled out of this control group, these patients, we pulled them out into their own group to say, okay, these patients, you know, they may not have EDS or HSD, but they have some hypermobility or they had it in the past. And what we interestingly found is the gray bar here is your controls. This pink salmon bar is your EDS patients, yellow, orange being HSD, and then the localized or historical being the red. And this is some of those conditions that the comorbidities that we looked at that were actually increased, yes, in EDS and HSD were higher than control, but these patients that we had, the localized or historical, actually were presenting with all of the same patients, the same conditions the EDS or HSD patients were presenting with, but actually even higher for a lot of comorbidities, for wheezing, joint pain, ADHD, constipation. And so we just, you know, this is very much a big push at Mayo, or something that's really important at Mayo, is individualized medicine. And this just shows us that it's not just individualized medicine in a EDS as a whole family. We really need to pay attention to who that patient is and what they need support on. So then, you know, the third pillar of Mayo and of our clinic is patients, and not just getting patients integrated from the start. You can build something with patient feedback, but if you don't continue to take that patient feedback throughout the process and grow and change for those patients, then your clinic is not supporting the patients properly. And so that was something that was really important in starting our clinic. So from that very first appointment, or before that very first appointment, we formed a patient advocacy or advisory group and had workshops where we asked the patients what was important, where we had sticky notes all over the walls with ideas or what the problems were and things like that, that we want, that they wanted us to address. And so we really wanted to integrate that from the start, but we still have those meetings monthly. So we have these patient advocacy meetings with a small group of patients on Zoom that gets feedback from their clinical experiences or other clinic experiences. We ask advice on clinical questions, not my clinical, everyone's clinical questions, but we ask advice on, you know, the questionnaire that they take. Is there anything that needs changed? Is there something that, you know, you were uncomfortable with? Is there something we need to change? Is there something that's missing that you really think is important that we need to understand about patients? And also, if there's something that we have interest in research-wise or clinical research-wise that we want to add to this questionnaire, we would send it to this group and say, hey, does this make sense? And they may help us reword. They may say, this question doesn't make sense, or hey, you didn't have this answer option. And so we have really used the advice of this group of patients to really keep improving and keep affecting the clinic. And then also we use this to help educate on new resources and support aids. And then they educate us on new, you know, oh, I found out about, you know, everyone knows about silver ring splints, but maybe there's something new, you know, like, and so they may know because they're seeing it from their big, huge communities that can help us then educate the patients. And then we also kind of give them updates on data and papers and things like that. And then we also at Mayo have this Ehlers-Danlos syndrome blog where patients as well clinicians and researchers can make posts to continue to educate each other. So what is the feedback that we've gotten from the clinic as well as from patients? So we don't want to just take that feedback to inform our clinic. We want to make that public. We want people to know, we wrote a paper about forming the clinic. We need to give, the community who may be starting new clinics the feedback that we are getting. We need to make that public too. And so this was a study that we recently published looking at patient feedback based on Ehlers-Danlos clinic follow-up. So they get a questionnaire sent to them after they have completed all of their referrals, they've had their follow-up, and we wanted to know what referrals are the most helpful. Where are we not supporting you properly? And so this top two graphs here are patients with EDS. Bottom two are HSD. This column here are pain-related referrals, and then these are other referrals. So what you'll see here, and they're rated by the most, what patients felt were the most helpful. They helped them improve the most after this referral. So acupuncture, both in HSD and EDS, sorry, I've switched those, but they reported the most improvement after those referrals. The least improvement was the pain rehabilitation clinic at Mayo, which is a long-term program there. So they actually had the least improvement and actually felt like they got worse after these appointments. And then our other kind of conditions, we had optometry had the best feedback. They had the best feedback, and the worst feedback, or the patients felt they got worse after them, was allergy and immunology. And so we take this information and then we go and say, okay, well, can we reach out to allergy and immunology? Can we find a provider within that who cares and wants to help support and be involved with patients? Because if a patient gets a referral, if we send them a referral to allergy and immunology and they get there and they don't feel seen, if they feel, like they're not listened to, then we're not supporting them properly. So we actually reach out to, and now we have an advocate within allergy and immunology at Mayo who can help support our patients, who wants to do research, who wants to help these patients clinically, who wants to learn. And so we are going to help these, 50%, 75% of these patients who had a bad experience, who felt that they got worse. We're trying to reverse that. So we're taking that feedback in our clinical care and our research. And then we also have a program at Mayo that's an EDS virtual education program. So after they get a diagnosis, they are invited to attend this program, which Jessica ran. And this is kind of a highlight of our feedback from that program. So this program focuses on group discussion, demonstration, explanation, examples, handouts, working together. And there's talks from physical therapy and OT, but then there talks from, pelvic health, women's health. There's going to be talks from all different areas that these patients could be experiencing. And so we collected some feedback on that and how they thought this clinic worked. And so we asked, did it help them feel like they had a better understanding? And this is grayscale, so it's hard. So I'll just, we saw that most of the patients, the majority of the patients in this gray and black, felt like it helped their understanding. It had them feel hope for improving. It made them feel like they had the tools, that they could address their needs specifically, and that they would recommend this program. So almost every patient, only one patient didn't agree, that this program could help them and help other patients. And so we've taken this feedback, we use this to then improve the education program as well as the clinic overall. So what are our kind of future directions at our clinic? We have over 2,000 biobanked specimens at our clinic that are being analyzed for studies. Dr. Fairweather is going to talk about some of those results, but we're constantly still researching, coming up with new research questions and using this to do that. We are seeing or collecting about 30 patient samples a week and seeing more clinical data than that a week, but we see about 30 30 samples are being processed in Dr. Fairweather's lab every week. And we really are focused, there's different labs focused on different things, different researchers. There's labs focused on genetics. There's labs focused on other things, but we really focused on the gene and protein pathways that are involved to try to understand the mechanism of disease to then help patients. So we're going to continue to investigate that self-reported intake questionnaire data that we get from these patients. We have over 4,000 patients, so we have lots of potential research questions we can answer with those patient populations, as well as helping them clinically. And then we are also able to pull information out of Epic, out of the medical record, to confirm self-reported findings. So if someone's reporting that they have POTS, then we can go look at their autonomic testing. We can look at their actual evaluations. We can look at their diagnoses and confirm those findings. We can go look at the MRIs and look and see if they have, nutcracker that is undiagnosed or things like that. So we're able to go in and use Epic to answer research questions that may have started with a patient or may have started with this intake questionnaire. So in summary, we have found, and I know Dr. Knight is bringing this here as well, and we hope other clinics across the US and world will really focus on this as well, as really integrating that clinical care. You're going to help that patient clinically, integrate the research, because that's patients are going to educate you in your research, and you're going to hopefully help move things forward in the clinic with research, and then have patient involvement at every step of the way. And so we have clinical staff and research working side by side to really accelerate discovery and accelerate patient care. Formation of biobanks and databases from the very beginning, or as soon as you can, are so important, because you may have a research question that you come up with in 2 years and you're like, man, I really wish I'd asked that question, or I really wish I had some blood to find this biomarker or to do something here. And so doing that from the very beginning is just so important, because when I have that question in 2 years, I have 4,000 people who've already answered that question. I have 2,000 blood samples that I can test. Advocacy groups and feedback from patients is huge. You have to make adjustments. You can't just get the feedback. You can't just publish a paper about the feedback. You've got to do something about that feedback. So you've got to go to allergy and immunology and find somebody for these patients that will have a good experience. You'll have to change the questionnaire. You have to take questions out. You add questions in. You use those adjustments. You don't just ask for feedback. You use that feedback. And then, a little plug here, basic scientists are awesome. So we can bring very unique perspectives to clinical projects, and working together, what a drug that's used in clinics started in a lab, that we make a difference from bench to bedside, and then bedside to bench. And that's really what we are trying to do here. Ooh. So I just wanted to acknowledge, of course, my co-research director, Dr. Fairweather, and our former medical director, Dr. Knight, because all of this data I presented and really all the work we've done since 2019, we've done together and with Jessica. And of course, you can't list everyone. This slide would be tiny. But Dr. Fairweather's lab processes, these 2,000 patient samples, processes these every day. Francis is here, one of the people who really helps keep our program going. And as well as Shulpa's here, the rest of our EDS clinic staff, clinicians, nurses, support. I am, like I said, I'm now at University of Florida, so I have my little lab now, and so I got to thank them for supporting me and our funding that really allows us to do this research and to really help patients in the long run. So thank you.
We do have time for a couple questions, if there are questions from the audience.
Yeah. So the question was, can patients who aren't patients at Mayo or maybe aren't at UVA, can they be involved in maybe providing feedback, taking the questionnaire, doing a blood draw? So it depends on the institution. At Mayo, the way our program works is the only patients who are enrolled are patients who are being seen by the EDS clinic. So I've had a diagnosis for a very long time, but I wanted to be involved in the research as well. So I actually went and saw Dr. Knight and had, because it's not just a diagnosis clinic at Mayo, and it's also if you need referrals, and things like that. So I used it for that side of things. But yeah, our clinic specifically, you have to be a patient at Mayo. There are different institutions that have different, so some of my other research at University of Florida, I can have patients come in and they can make them a medical record and they can come do blood draws and be involved. But our clinic at Mayo is you have to be a patient. But that could be something that is thought about here. Yeah, but there is studies, of course the people here aren't the only ones doing, there's research people who are doing remote blood draws or remote surveys. And I think a lot of that's listed on the Ehlers-Danlos website. So there are abilities to do remote studies and things like that. So I would direct you to the society. Oh, and, yeah.
You mentioned the number of patients.
Yeah.
I'm wondering how many patients have been lost by both clinics. For example, I've known my entire life that I've had hypermobility of some sort. I came across the term Ehlers-Danlos kind of randomly in 1996. Seems like it's pretty close to what I'm dealing with. I was living in Minneapolis, St. Paul before the pandemic, and my doctor referred me to Mayo Clinic. I did the big intake with your triage. I did multi-hour form, and what I got, I had no idea that you had EDS clinic.
Yeah.
But the feedback that I got was, we can't help you. You know as much as we do about your situation. Go away. I had my doctor restart that, and she got exactly the same feedback. Then I moved to Virginia in 2021. I signed up for UVA genetic clinic in 2022, and I only found out about the EDS clinic here by a random Google search of something else that apparently I have been lost in the system also at UVA. So how many other patients are you guys losing and not including in your studies or anything else too? And how many people are getting frustrated because they've been dropped by both?
Kind of paraphrase our question.
Yeah. Of course. The question was how many patients are getting lost because she had an experience where she was lost from the EDS clinic where they said they couldn't help her specifically at Mayo. And UVA. Yeah. So I will speak to the time when we first started this clinic, the initial thought was the clinic was only going to be for diagnosis. And we really fought that as people, because you need that clinical, someone may have a diagnosis, but they don't have the support. They don't have the referrals they need outside. And so we tried to make that improvement. I think when you were talking, that's when that happened. The other side of things, we do lose patients at Mayo because there is insurance issues. Mayo Clinic doesn't take Medicare. And so that affects patients for sure, and we lose patients that way where we're not able to support them, unfortunately. And then the other thing about our clinic is it is very much you get either the diagnosis or you get the referrals, and then you are expected to your primary care is expected to manage you. It's not a management clinic; it's a diagnosis and coordinated care clinic. So we are gonna, you're gonna lose people, because of that. So, we all wish that we could help every single patient, and we know that we lose people and that we aren't supporting people the way that we should every time, but we are trying. So we made that improvement. We knew that there was an issue, that it's, these patients don't just need diagnosed, they need that support. You may have a diagnosis and have never seen a neurologist and you have daily migraines because you never got that referral, and we want to help that side of patients. But we can't, unfortunately, help everyone, and I wish we could, but hopefully between the different ones, people who may have been lost can get found.
Yeah. Time for just one more question. I think it was one over here.
I have 3 kids all with and my wife researched roughly 50 doctors. And you probably had hundreds, all kinds of abnormalities that are relevant. And I think what you miss, if a lot of we're looking for patient feedback, that I think parents are
Yeah.
our kids. On any given day, you can talk to them and say, "Fuck, doesn't fall." Well, they have participated yesterday, they had fought or any other number of things, and they sit in front of you on a questionnaire and they say, "No, I'm fine."
My mom does that too. Yeah, of course. Yeah. The question was about making sure to, or statement, more way, a suggestion is to make sure you include the patients or the parents of patients, whether they're very young or even in college, in the collection of information clinically and for research. Our clinic at Mayo can only see patients 16 and up, and they have to consent or assent, and the parents have to consent, and they are involved. And can't speak clinically, but I am sure, Dr. Knight, I can speak for the fact that my mom has Ehlers-Danlos, and I made her come to the clinic. My sister came, and I was in that room, and mom be like, I get a headache once a month. And I was like, no, you get a headache every day, So, it goes both ways. We take care, they take care of you, and then you take care of them. And so I know for a fact that Dr. Knight and the EDS clinic at Mayo listens to the parents and children, to make sure that they get the whole story, that they can support everything that patient needs. So thank you. I'm here all week.